Welcome to the Positive Pharmacist channel. Thank you for watching this video. Please don't forget to subscribe, ring the bell, and leave comments of topics you would like to see in the near future. Today we will be doing a review on dyslipidemia. So there are two main types of dyslipidemia. There's the primary, which is genetic, and the secondary, that's normally due to the diet or the lifestyle. So that one is acquired. So the treatment options that I will be showing are based on the ACC/AHA guidelines for dyslipidemia. So currently, the newest guidelines show that there was no evidence to support treating patients to the LDL target levels. So we're not looking at the numbers of the LDL going down. We're looking more at treating patients for the risk or for actually having ASCVD. The drugs that are primarily used in this case are the statins, and you'll see that we'll spend a lot more time talking about statins because they are the first line drugs used unless a patient does not tolerate statins after multiple attempts, which we will explain later. After, if the patient does not tolerate statins at all or it's not indicated in that patient, then we can go on to use non-statin options. There's a study that was done called the Improve It study that had the results showing that whenever statins are used in addition to ezetimibe, also known as Zetia, it showed greater effects than statins used alone. And this was tested in patients, unstable patients who had a recent acute coronary syndrome. So that acute coronary syndrome is one of the things that falls into ASCVD, which is the atherosclerotic cardiovascular diseases. So if in a stable patient with the recent ACS, statins and ezetimibe showed greater results in terms of less cardiovascular events than using statins alone. So there are three main intensities of statins, if you want to put it that way. The first one being the high, and the moderate, and then low. So the percentages there show you how much of the LDL, what percentage of the LDL is being reduced. Yes, we did say that we do not treat based on the LDL target levels, but we still want to know which ones, how these drugs work, and how much effect they are going to have on the LDL. So the high intensity statins, there are only two of them, very easy to remember: the Lipitor and the Crestor at the higher levels. So Lipitor from 40 to 80 milligrams per day, and then the Crestor from 20 to 40 milligrams per day. Those are the only two that fall into the high intensity statins category. So you want to make sure you know the brands and generics, especially if you're studying for the NAPLEX exam. Make sure you know your brands and generics. It's a big part of being a pharmacist. You want to really make sure you know them very well, so that even if the question comes with a brand and generic name, you would be able to know where that drug falls in terms of intensity. So when we're looking at patients, we want to put them into one of these, I would say, four main categories, and they are called statin benefit groups. These are based on their ASCVD risk, and the ASCVD risk is looking at the 10-year risk of a patient having either a transient ischemic attack, a stroke, a peripheral artery disease, any of those type of things in the next 10 years. So if the risk is 7.5% or higher, then the patient would have a greater risk compared to someone who has less than 7.5%. So we'll first look at primary prevention. So primary prevention, these are patients who have never had an ASCVD in their lives, but we want to prevent them, but they are at risk for it. So either because of their levels of LDL, or because of their medical report, like being a diabetic or other things involved, which we'll discuss. So in the primary prevention group, we want to look at patients who have an LDL of 190 and higher. Those patients will be placed on a high intensity. These are not set in stones. So if a patient falls into that category, and let's say they are 75 years old, or they are elderly and cannot handle a high intensity, it's not set in stone that they have to be on it. You have to look at your patient as a whole and make sure that they are able to handle that particular drug. So we'll start with a high intensity, and depending on how the patient tolerates it, you may need to lower down to a moderate or even to a low, depending on that specific patient. But the recommendation is that if the LDL is 190 or higher, you give a high intensity statin. The second category we're looking at is diabetic patients who are between the age of 40 to 75 years old, with the LDL between 70 to 189. So they do not quite reach that 190 mark. So diabetic between 40 to 75 years old with the LDL between 70 to 189. So if they have the ASCVD risk above 7.5% or above, it's a high intensity. If it's lower than that, it's low intensity. It's a moderate intensity, so a lower one. We're also looking at patients who are 40 to 75 years old with the LDL 70 to 189 without diabetes. And these patients, you have to look more at the patient as a whole and consider whether you want to put them on a moderate initially or a high, and then go back to a moderate depending on how they tolerate it. Secondary prevention means the patient has an ASCVD before, and now we want to prevent them from having a second round of it. So we want to prevent they had a stroke. We want to stop them from having another stroke by placing them on these statins. So we're looking, again, specific groups. We're looking at a 75 and older with ASCVD, or less than 75. And if they are less than 75, they are younger. So we want to try the high intensity first before going down to moderate if they cannot tolerate it. And then if they are greater than 75, they are the elderly, we want to do the moderate intensity first. So now we'll go into the side effects of statins and how to manage the biggest side effect, the most common side effect that can happen with statins. So first, we'll talk about the contraindications. When you see a statin, you know pregnant women cannot have it at all. Breastfeeding women cannot have it. If a patient has active liver disease, it's a no-no, because these statins are going to affect the liver enzymes. They are going to elevate them and damage the liver. So the side effects that we want to look at is muscle soreness, weakness, or any aching of the muscles. If that occurs with the patient needs to, they can talk to their pharmacist, of course. That's why we're there, to intervene for them with the doctor, so that the doctor can make changes for that patient, because we are the most accessible healthcare professional, especially in the community. So if that occurs, the patient can either talk to their pharmacist for intervention or talk directly to the doctor so that changes can be done. Liver damage can also occur. So we'll see possible liver damage by looking, for example, if the patient sees a yellowing of the eyes or skin, that's a sign that the liver could be damaged, of elevation of the liver enzymes such as AST and ALT. So with these enzymes, of course, in the community, we do not have access to the patient's lab reports, but a medical doctor can draw some sample from the patient in order to look at whether or not the liver enzymes are 3 times the upper limit of normal for that patient. So if it is 3 times upper limit of normal, this drug will need to be stopped, because at that point it has done a lot of damage. While the patient is on this drug, they want to avoid any grapefruit juice, because it's going to increase the amount of the drug in their blood. And so, especially with patients who are at higher risk of experiencing these muscle soreness, do not forget to stress that. All patients should be counseled on it, but do not forget to stress it, especially if a patient is already having an issue with a statin, or with one statin or the other. How to manage the muscle pains, also called myalgias. So the doctor will need to hold the drug and check the CPK level. CPK stands for creatinine phosphokinase, and those are a type of proteins that would be elevated in the blood to indicate muscle tissue injury. So after the doctor pauses it, the patient needs to go on a statin holiday. That's how that's how they called it while I was in pharmacy school. The patient will go on a statin holiday, where they are off of it for 2 to 4 weeks, and then the patient can be re-challenged either on that same statin at the same dose or at a lower dose, depending on the clinical judgment of the doctor and the pharmacist. And then after that, if the symptoms return after the patient has been back on the statin, even at a lower dose, then a different statin may need to be tried. Usually, one of the statins that's most tolerated is the pravastatin. Pravastatin is very well tolerated by most people. But that's just a side note for you guys. So two main statins that are taken at a different time of the day compared to the others. The other statins can be taken at any time of the day, but there are two specific ones that have to be taken in the evening. And I remember them because both of them end with core in their brand name. So there's Zocor for simvastatin and Mevacor for lovastatin. So Zocor and Mevacor are taken in the evening, but Mevacor is specifically taken with the evening meal. So Zocor just has that counseling point to administer it or to take it in the evening, but Mevacor specifically says to be taken with evening meal. That's when it works best. It's best absorbed that way. Statins drug interactions and the maximum limitations for certain drugs. So we'll focus on this slide on 3 main statin drugs, one of them being the atorvastatin. With the atorvastatin, we want to remember to avoid any cyclosporine. Of course, it has other drug interactions with many other things, but for this specific slide, we want to remember avoid taking atorvastatin with cyclosporine, and when we review the charts of our patients, we want to look out for that. When it comes to simvastatin, there are 2 different maximum for this drug, the 10 milligrams a day and the 20 milligrams a day, depending on which other drugs the patient is taking simultaneously. So with the 10 milligrams per day, if the patient is also on verapamil, diltiazem, or dronedarone, we want to make sure we do not exceed 10 milligrams with the simvastatin. If the patient is on amiodarone, amlodipine, ranolazine, and lopidamide, we want to make sure we do not exceed 20 milligrams. If you look carefully, you will see that a lot of the drugs, all of the drugs actually from the Zocor side, simvastatin, are also seen that could possibly cause an interaction or cause increased muscle pain in the patient with the Mevacor lovastatin. So the only 2 ones that we see that are new on the lovastatin side is the ticagrelor and the donazole, the ticagrelor and donazole. So those are the only 2 new ones on that side. Non-statins that are used, we'll start with ezetimibe. In terms of safety concerns, so such as side effects or contraindications, they are similar, especially when it comes to contraindications. If a patient is on Vitarin, You want to be careful. If a patient is on Vitarin and that patient happens to be pregnant, this is not good. You do not want to use Vitarin because Vitarin contains both the ezetimibe and the Zocor. So it contains both ezetimibe and Zocor at 10 milligrams each. So now if the patient is on Vitarin, you want to remember the limitations, the maximum limitations of simvastatin at 10 milligrams and which drug it was interacting with, which drug you do not want to exceed the 10 milligrams with. So remember that Vitarin is both Zetia and simvastatin. So the statins contraindications would apply. If you remember, it was pregnancy, breastfeeding, as well as liver disease. So Zetia is taken with or without food. There's nothing really to stress there. Fish oils. The two main ones that are very common on the market, Lovaza and Vascepa. These are taken whole. You can see on the right side, I tried to place an image there of what they look like. They are very, very big pills if you see them in person. Very thick. They look like horse pills almost. So the patient has to take it whole. They cannot break it. They cannot chew it. It has to be taken whole. The fish oils are usually considered when the patient has triglycerides level 500 or more. 500 or higher. At this point, the patient could be at risk for pancreatitis caused by triglycerides. So we want to place them on fish oils, for example. Some side effects of fish oils are burping. Patient could be burping. They could have upset stomach, or it could affect their sense of taste altogether. Fish oils can also increase the INR. This is the key thing to know if the patient is also on warfarin or if the patient is on warfarin, you want to make sure you monitor their INR while they're on the fish oil because it's going to increase it, which is going to increase their chances of bleeding. Next, we're looking at the bile acid sequestrants. The two that we're looking at is cholestyramine and the cholesevelam or Welchol. So with these drugs, they interact with a lot of other drugs. We want to make sure we space them apart from other drugs by 4 to 6 hours. So the other drugs should be taken either 4 to 6 hours after the bile acid sequestrants or 1 to 4 hours before. These are contraindicated in any bowel obstruction, or if the triglycerides are elevated, or again if the patient has pancreatitis induced by high triglycerides. So with the fish oils, that's when you want to use it. With the bile acid sequestrants, that's when you want to avoid it. But usually the guidelines, the ACC/AHA guidelines recommend that if a patient is already has the triglycerides of 300 and more, just stay away from bile acid sequestrants altogether because they can elevate the triglycerides. So just stay away from them. Even starting at 300 is not recommended, but it's definitely contraindicated at 500. Some side effects of these drugs include constipation. That's the most common one that you want to remember. You want to separate these drugs also from multivitamins because they affect the absorption of the fat-soluble vitamins. Fat-soluble vitamins are easily remembered as ADEK. That's how I remember it, ADEK. But specifically the K is affected. So we know that if there is a deficiency vitamin K, then there's increased risk of bleeding, especially again if the patient is on warfarin. If the patient is on that blood thinner, then you want to be careful with the bile acid sequestrants and monitor that, because the patient may actually need to be on a multivitamin just to supplement those fat-soluble vitamins that are not being properly absorbed. Other non-statins used, we look at the niacin, also known as vitamin B3. So niacin has 3 different formulations. There's an immediate release called Niacor, an extended release called Niaspan, and the slow niacin is the sustained or controlled release form of it. So the reason why the Niaspan is bold it and underline is because that's the best one recommended to use in patients when niacin is to be considered. So niacin reduces both triglycerides and LDL. So if a patient has those two as an issue, niacin is a good one to consider. But you want to look at extended release niacin to use and not the other two. The reason being that the immediate release has a lot of flushing that happens with it, while the sustained or controlled release has a lot of liver damage that happens with it. But with niacin, it was found that it didn't have the issues that the other two formulations have as much as they do. So it was a little less with the niacin. So that's the most recommended one in terms of niacin. The contraindications for niacin include active liver disease or active peptic ulcer disease. Some of the side effects, we mentioned the flushing that happens, especially with the immediate release. There's itching. It can increase the blood sugar levels in diabetics. It can also increase the uric acid level, so it could cause gout in a patient. So those will need to be monitored definitely. But with the flushing, if the patient is on the immediate release Niacor, because niacin, even though it's great, it's actually on the expensive side. So if a patient needs to be on another one that's a cheaper version, the immediate release has flushing happening with it, but it does not have a lot of liver damage that can occur. So if the patient is placed on immediate release, they can manage the flushing by taking either aspirin 325 milligrams or ibuprofen 200 milligrams at least 30 minutes before the dose with food, of course, because these are NSAIDs, and you want to make sure that your patients take it with food to avoid any upset stomach or any bleeding in the stomach possibly. So flushing can be managed with either aspirin or ibuprofen. Most commonly, people recommend aspirin, but either one of those can work, taken at least 30 minutes before that niacin dose. We're also looking at the fibrates, so mostly fenofibrates and gemfibrozil, also called Lopid. The fenofibrates have a lot of brand names, but out of the many brand names that they have, there are two specific brand names that have to be taken with meals, and those are the Phenoglide and the Lipofen. The Phenoglide and Lipofen have to be taken with meals, while everything else can be taken with or without food. So with the gemfibrozil, taken twice a day, and these are taken in half an hour before breakfast and half an hour before dinner. With these ones, it interacts with a lot of drugs, especially the repaglinide, and we see Zocor again, simvastatin. So repaglinide is a drug used in diabetes. We want to avoid that drug and Zocor when the patient is on gemfibrozil. There are many other options, many other drug classes that they can use instead. In terms of contraindications, liver disease is another one that keeps coming up with these patients who are treated with statins or non-statins, liver disease and gallbladder disease with the fibrates. The main common side effect with the fibrates is the upset stomach. Fibrates usually are used to reduce triglycerides. So again, you want to remember niacin reduces both triglycerides and the LDL, but fibrates reduce just the triglycerides, just like the omega-3 fatty acids. The last non-statins that we'll be discussing are the PCSK9 inhibitors. The two main drugs under that class is Repatha and Perluent. So far in practice, I've mostly seen Repatha used, and after we go through this slide, you'll understand a little bit why it's mostly Repatha that we see prescribed to patients instead of Perluent, because Repatha is a little more forgiving in terms of for getting it outside of the refrigerator. But these drugs focus on reducing the LDL levels. So the side effects that the patient should be aware of is mostly injection site reaction and possibly runny nose in some patients. So these drugs are usually administered every 2 weeks at lower doses or monthly at like 3 times the dose that the patient would have been on every 2 weeks. So those are the recommendations, but you have to look, of course, at the specific dose. But it's not something that has to be stressed because that information is always available to us. But you do want to know the frequency. But in case you are not sure about the actual dosage of the drug, of course you can look it up. There are so many clinical sources that we can have access to as pharmacists. If you remember, that's great. Hats up to you. Missed doses with these drugs, it's very, very important to counsel your patients on when, if they ever miss a dose. No one is perfect. Sometimes we forget to do some things. Sometimes we forget to take a drug that we need. And with the Repatha and the Preluent, Repatha actually has an indication to help prevent strokes in patients. So if a patient misses a dose, you want to make sure you let them know that they can take it within 7 days of the day they were supposed to take that missed dose. And then the following dose is not going to be just a week after. The following dose is going to be 2 weeks after that missed dose is taken. So key, very important counseling point there for missed doses. Repatha at room temperature can stay out for up to 30 days, whereas Preluent can only stay out for up to 24 hours at room temperature. Once it has been warmed up for injection, that's it. Can only stay out for up to 24 hours, but Repatha can stay out for up to 30 days. So those are key points to remember when we're counseling our patients, and I believe that's a reason why Repatha is more common now in practice versus Preluent. And on that note, that's all I have for today regarding dyslipidemia. I hope you guys subscribe, and click on the bell to receive notifications in the future. And please leave comments below about other topics you would like for me to cover to better help you in your studies as you go through pharmacy school or as you study for your exams. Have a great day. See you next time. Bye-bye.